Welcome. It is October 17th. Our patient is having a cervical Deuk laser disc repair, C5-C7. She is a very challenging patient. She's physically very large, short neck, and we are unable to intubate her, so we have her on an LMA. Can you see the x-ray, Sanjay?
Yes, doctor.
All right, show us where the tear is in the back of the C5-6 disc. There's a tear right there. You see the dye leaking out into the epidural space. So she's here from Indiana, and she has two herniated discs in her neck that are causing symptoms for her. Number C5-6 and number C6-7. Shot. Very good. That's it. 2, 3, 4, 5, 6. You agree, Luis? We're at 5, 6. Okay, we're going to numb up the skin. We're going to get started. So she has a very short neck, which makes it very difficult to do the surgery. She also has a thick neck, and she has a difficult airway. Wipe. Our anesthesiologist made 3 attempts to intubate her with an endotracheal tube. Now I need to see where the pool is. And he was unsuccessful. So we had to resort to second best option, which is called an LMA. It stands for laryngeal mask airway. Basically, you put a mask over the entrance of the laryngeal inlet. Thank you. 2, 3, 4. And you have to ventilate above the vocal cords. All right, I feel good there. We made our incision. We're going to get started. I'm taking the needle out, leaving the guide wire in. We're going to do this surgery arthroscopically. She did not want a fusion. She did not want metal in her neck. She wanted the Deuk laser disc repair, which is a natural repairing of the herniation. We assist the body to heal it naturally. We're placing our dilator. She doing all right? Yep. We've made a 4mm incision. Shot. Is that where we are right now? I've got to watch the guide wire, make sure it doesn't advance. Shot. Because it's at the back of the disc. I don't want it going any further back. Shot. Now I'm advancing the dilator over the guide wire. Shot. No, that little thing is there. Shot. We're almost at the spine. I'm a little bit on her left side of midline, which is fine. As long as you're about 5 millimeters, maybe up to a maximum of a centimeter off the midline, it's okay. It's preferable to be in the midline. Shot. That's pretty good. So you can see the tip of the dilator is right where the spinous process is. You can see the tear. Show us the tear. It's actually worse on her right side at this level. You can see the dye leaking out. Yep, show it all the way out. And there's the nerve that it's surrounding. Okay, we're going to fix the number 5-6 herniation first. Any questions, Sanjay? Shot?
No questions.
All right, very good. So far, it's been very challenging, but we're okay. I think so. Shot? Yeah. So here's what I'd like to do. I want to try to advance. If you can give me a little bit of inline. Shot? Try to get this just started, and then we can advance it. Shot, I feel it going. Yeah, we're going. Shot. I want to bring my dilator all the way to the back of the disc where the herniation is, which I've done. Then we're going to do the entire surgery through this tube right here. It's called a tubular retractor. It's 4 millimeters wide on the outside. On the inside, it's around 2.8 millimeters wide. So basically, the entire surgery is being done with a 3 millimeter tube passage. far smaller than any other surgery that's done on the spine. This is a technique that was developed by the South Koreans, by Dr. Sang-ho Lee, who trained me. He probably doesn't even remember who I am. That's the funny thing about it. Dr. Sang-ho Lee is a big name in Korea. He started the Woodidal hospital system. Shot? All right, at this point I will need a little bit of inline, a little shoulder pull. Hold on, not yet, not yet. All right, I'll tell you when. Shot? That looks great, that's enough right there. Just everybody stick there. Berndes, are you giving me a little shoulder, a little neck inline? Perfect. Yes, yes. It all helps. Any questions?
No questions.
Almost there, almost there. Stay with me. All right, folks, if you have questions, feel free to ask. Shot? There we go. We made some progress there. Shot? All right, I'm going to advance the dilator just a smidgen, and then I'll advance the tube over the dilator. Watch that. Shot? Shot, I felt it go. Perfect, now let's advance the tube. We're putting our tube in position to do the surgery. Shot? Almost there, guys. One more minute, we're done. I'm advancing the tube. Shot? Just a smidgen more. Shot? That's perfect right there. All right. Thanks, everyone. You can relax. We're done. Let's get the scope in, and we'll start lasering this herniation out. You can see the entire surgery. We've lost. Sanjay, you see this?
Yes, doctor.
How many drops of blood do you see?
Barely minimum.
Basically 3 drops of blood, right?
Yes.
3 drops of blood. That's how much we'll lose for the whole surgery, about 3 to 5 drops of blood. So this surgery, the endoscopic Deuk laser disc repair, is actually bloodless surgery compared to the open surgeries where you lose a lot of blood. All right, here we are.
Thank you.
We are now at the bottom of this tube. We're inside the herniation. We're actually at the back of the disc. You saw on the x-ray the position of the tube. And beautiful view through the scope. I need help here. People ask me, why doesn't the laser burn the nerves and tissues? It actually would if it wasn't for the cold irrigation that we run through the system constantly. That irrigation has several purposes. One is to cool the laser tip and the tissue so they don't burn. The second thing it does is it removes the debris, which is the broken up pieces of herniation. The third thing it does, as you can see there, is remove blood. So it removes blood, it removes debris, and it cools the laser. I need help here. Yeah. I think our light intensity is maybe okay. I may want to put it down one notch. Yeah. So when you're doing these kind of surgeries, you have to pay attention to the intensity of the light because you can actually have it overexposed and then you can't really see what you're doing. You don't want that.
So with your hand there, Dr. Deuk,
Yeah.
I'm having trouble ventilating. Is there a way you could loosen a little bit on your left hand? A little bit?
My hand isn't touching anything.
Oh, it's better now.
Huh?
Sort of
It's better now? All right.
Sorry about that.
I'll just try to keep my hand off. God damn it, piece of tissue is sitting there blocking our view. All right, Sanjay, let's show the audience how herniated disc causes pain. Welcome back. So far, the surgery is going well. We had, a little bit of issues getting in here because of her, help me, right here, this is catching, because of her, a lot of things, her anatomy. It's a short neck, it's the thick neck, it's the chest is huge, and it's pushing on my instruments, blocking me from doing what I need to do. So these are all things that there's no way you can predict it's going to be an issue ahead of time. And then of course we have the airway issues, which we're unsuccessful at getting her intubated. So we're using an LMA right now, which is a laryngeal mask airway, which is fine. It's not ideal, but it is acceptable and it's working. And we've done it before. Doesn't mean we want to do it again. Yeah, Dr. Berndes is reminding me we've done it before and it works. But it's one of those things, like if you're going to go out for a drive, you want it to not be raining. You want it to be sunny and clear, good conditions. That's how surgery is, And every time we go into the operating room with a patient, we just don't know what the conditions are going to be. She's a larger lady. So there's a chance that we're going to have issues.
This is stripper, please. Stripper, please. Lights on.
We just broke our laser fiber. It's okay?
Yeah.
So it may have damaged. Oh, no, we're okay. Wait.
We're okay. Just having some wait.
Wait. Let's get the lights back off. Let's get back in there. Our fiber just snapped because we're fighting her chest so much just to get down there. Our laser fiber broke. Hold on. And you want to hope that it didn't melt the metal, because it can melt the metal quite easily. And thank God it did not. Let's keep an eye on that. I don't see a good tip. We need to strip it. Here you go. Take it.
Yeah, lights on, please.
So our fiber is a 1 millimeter half a millimeter fiber. Can you see, Sanjay?
Yes, doctor.
Let's show the audience. Can you see me?
Yeah, yes, doctor.
All right, great. You see this right here? No, I don't need that.
Yes, I can see that.
Yeah, just focus on that. This is our laser fiber. It's covered in blue plastic, but there's a little glass fiber there that transmits the laser energy. Just to give you an idea, the actual blue part is a millimeter, right? You see that?
Yes.
But the fiber, the laser fiber, the glass part that transmits the laser energy, it's inside the blue covering, and it's half a millimeter. Here, look here. Can you see this?
Yes, we can see that.
You can see it better with the blue background. Can you zoom in and show the audience?
Yes, we are zoomed in.
You can see the tip, the glass tip is half a millimeter. So people ask me about precision. This is the most precise instrument in surgery. And the way I use it in this scope. You see the scope here?
Yes, we can see that.
This is the scope. And we actually introducing the laser fiber down the channel. You see that?
Yes, we can see that.
And then it comes out the end. You see that?
Yes.
This way I can irrigate it, I can observe it, and I can move it around. All right, scope on.
Please. Thank you.
All right. Let's get back in business here. So you can see the blood there. We had to use the irrigation to clear it. So, okay, hold on. There. Once again, we're fighting her anatomy right now to get access to the foramen on the left side. We are really struggling here. Almost done.
5 minutes?
With this level, 5 minutes is about right. If I could just, it's her shoulder. Can you pull her shoulders, please? If I could just get another millimeter. There we go. Let's show the audience, Sanjay. exactly how the Deuk laser disc repair surgery works. C7. We can see it there. To do that, I'm going to first remove this tube. You guys see the tube here, Sanjay?
Yes, we can.
How it enters? That's basically a 5mm, in this case, incision. So I'm going to remove the tube. I'm going to leave the dilator in place. Shot. And once I do that, I can get this tube out of the way. I can actually move the dilator south to the number 6-7 disc. All right, doctor. I'm manipulating this patient's neck a little bit. Shot? Yeah, I'm at what?
Trying to get less pressure.
Oh, yeah. Okay, now we're all going to make a move here, and I'm going to lift this dilator out of the disc, and I'm going to go south to the next disc. So let's all do our best to show the spine. Shot? That's pretty good. Yeah, I see it. That's perfect, guys. Stay right where you are. Everybody stay where you are. We're almost there. Shot? I'm out of the disc right now. I'm on the front of the spine. Shot? I can feel it. Now I got to make my way south. Let's get an AP. Nobody, don't relax too much. We want to make sure I'm in the middle of the spine. That's good. Now lateral. So I am in the middle. I'm going to try to make my way down south. You guys ready? That's very pretty. Just stay where you are there. I'm actually dissecting. Shot. Very good. I need to get another AP. I was dissecting with the dilator. Now this move you're watching, nobody in the world has done this except here at Deuk Spine, myself. I pioneered it. It's called the Deuk Spine Slide. And it's basically moving from one cervical disc to the next. And again, in Korea, they don't do this. They basically treat one disc at a time, and then your surgery's over, and you have to come back and get the other disc fixed later. But for me personally, no, we're good. Right there is perfect, yeah. For me personally, I didn't feel it was right to make people come back. You know, I want to try to fix it all in one surgery. So I developed this technique. Stay where you are, let's get an AP. Basically sliding down the front of the spine. Shot. I'm almost there. I just want to make sure I'm in the middle. If I'm not in the middle, it's a problem. You don't want to be off to the side of the spine. It would be very bad. You need to be in the middle. So here we go. I'm going to slide just another few millimeters. You see the bone spur shot? I got over it. Right on the edge. Okay. Oh, there it is. Shot. I think I popped over. I felt it. See, you got to really be good with your fingers. And, you know, most neurosurgeons are, but not all. You got to feel everything. You got to understand what you're doing. But the hands and the feeling are everything. This is not possible with robotic surgery, by the way. Okay, so people ask me, do you do robotics? No, I do human surgery. And there's no robot that can do this better than me. I don't need no stinking robot. AI I need. AI we need, but robots we don't need. Okay? All right, shot. That's it. AP, let's just make sure we're in the middle. There's our third drop of blood for the surgery. Remember, this is a bloodless surgery. We've had 3 drops of blood. So if you're a Jehovah's Witness, you don't want to lose blood, you don't want to get a blood transfusion with spine surgery, I'm not ready. I need to advance it more. This is the perfect surgery for you. The endoscopic Deuk laser disc repair. Is that us? Yeah. All right, so we're heading into the disc. Shot. And I got to admit, this disc is pretty degenerated. Shot. I can feel it. All right. At this point, I'm going to clean the disc material out of the little tube. Any questions?
Yes, we have a question from Pompano
Let's
Mike.
pull. Pompano Mike, how's it going? Welcome back.
Are there times when you are trying to remove the herniation, you wish you could articulate the laser tip or the grabber?
Shot? No, there are not times that I wish I could articulate the laser tip or the grabber. Mike, you can see the discogram there. We got the dye in there. There are times I wish I didn't operate on certain patients. No, there are times I wish patients' anatomy was a little more conducive to surgery. But there's not times that I'm in need. And I'll tell you why. I'm a big believer in science. And science, the fascinating thing about science is that if you are a true scientist and you understand data and you understand facts, you know that this surgery has been performed this way, the same way I'm performing it right now, for 17 years, and we've not had a single problem in terms of the use of the laser. It's always worked, and the results are consistently excellent. Basically, complete relief of the discogenic symptoms. So I've never had to go say, oh my gosh, if I just could have done a little different with the laser in the surgery, I would have had a better result, because it doesn't exist. That situation has never existed. So to answer your question, I just look objectively at the results that we have in the data, and I realize that our results are perfect and that we couldn't do better than perfect. So I wouldn't want to change anything for that reason. Shot? All right, I need a good pull from everybody. Wait, slow down. Shot? Why are we getting such a bad image? All right, inline traction. Yep, let's keep going. We're making progress. Shot? Is that it? Shot? Give me a little more, folks. Shot? Almost. Getting there. We're making progress. Shot? I feel it. We're moving. Shot? Excellent. I want to that's fine. All right, good job, everybody. That was hard. And let's count, Jordan, on that x-ray. Stay with the x-ray, Sanjay. C2,
Copy that.
3, 4, 5, 6, 7. Nobody said spine surgery was easy. And what makes it challenging is the variation in anatomical situations, aka the patient. All right, any other questions or comments?
Yes, we have a question from Big John on YouTube.
Hello, Big John.
I have a chicken or egg type question.
Okay.
What generally comes first with a long-term cervical issue? Arm weakness or arm atrophy?
Oh,
Can you have atrophy without weakness
No.
or weakness without atrophy?
no, great question. Atrophy, for those of you who don't know what we're talking about, is loss of muscle mass. That I need 10 minutes. Dr. Berndes, 10 minutes. So atrophy is when you look at your muscle and it's shriveling. The only way your muscle could be shriveling is with two things in the world. One is nerve damage, the other is muscle damage. Now, there's only a few things that cause muscle damage, and one of them is called myositis. There's also muscular dystrophies where you lose muscle mass, okay? Muscular dystrophies. And there's a bunch of them, like Duchenne's muscular dystrophy. So you lose muscle mass, you get atrophy from either muscle problems or you get it from nerve problems, pinched nerves, because the nerves are what make the muscles contract. You know, your brain talks to your muscles through your nerves. So pinched nerves will first cause weakness and then atrophy, okay? Unfortunately, a lot of patients don't recognize the weakness until it's too late, and they have bad atrophy, or they're in denial. I hear it all the time. Oh, I need to go to the gym more. I need to work out more, you know? No, that's not the problem, actually. The problem is really that you have nerve damage. So, weakness and atrophy when in the setting of pinched nerves they're both very, very bad. This is all scar tissue within the annular tear. This is what's causing all of our symptoms. It's from the herniation, and this is an old disc injury. You can already tell. This injury is old. It's got a massive amount of scar tissue that we're dealing with here. All right, keep the questions coming. Happy to answer them. So I'll just make a few comments while we're waiting. There's a piece of herniation right there. Herniated discs are never one herniation. They're always multiple. I've never seen a solitary herniation. And when people talk about, oh yeah, I have these episodes of pain, what they're saying is, I herniated, I got symptoms, my body tried to heal it partially, it got partially healed, symptoms got better, then I herniated again, symptoms came back a few months later. Until eventually you have enough herniation, you're just always suffering in pain. My advice, get it fixed. This is the best surgery in the world for that. For any kind of a disc problem, bulging disc, ruptured disc, herniated disc, slip disc, protruding disc, extruded disc, any type of disc injury, this is the surgery you want. The alternative to this would be a fusion or an artificial disc. I don't recommend those. They're invasive and completely unnecessary. Who wants a chunk of metal in their spine? Who wants to lose movement in their spine? I wouldn't. I've done 1,000 fusions in my career, 1,000 cervical fusions. I've done about 1,000 lumbar fusions. I've completely stopped doing fusions because these surgeries work so much better than a fusion. And there's no need for post-operative painkillers with these surgeries. These people take Tylenol after surgery. They don't take narcotics. They don't take any other painkiller other than what they came in on. And of course they have to take that, otherwise they'll go through withdrawals. So you can taper off of those painkillers after surgery. Watch your hands, I don't want to hurt you. All right, great questions so far.
We have a question from Premier Media Group on YouTube.
All right, we got some of our heavy hitters here today. Welcome.
How do the nerve damage and muscles recover after successful DLDR?
All right, I couldn't understand the question.
How do the nerve damage and muscles recover after successful DLDR?
Right. So the question, I think, and I'm going to repeat it so everyone can understand it. I believe the question is asking me, how do the muscles and the nerves recover after a successful DLDR?
That's correct.
Yeah. So the answer is very simple. If you the problem with the nerves is that they're being pinched and irritated. So any surgery that unpinches the nerves, whether it's a ACDF, PCDF, DLDR, as long as the surgeon has successfully unpinched the nerves, then the nerves have the best chance of healing. Okay? So I'm going to discuss that scenario. It doesn't have to be the DLDR, because the DLDR is very successful, as successful as, say, an ACDF that I do. Now, other doctors do not do ACDF the same way. There's a lot of bad surgery out there, a lot. Okay? I see it all the time. Bad results, bad results. I'll be honest with you, I just saw a patient that shocks me. He's a doctor, I won't mention his name, but this doctor has been in practice for many years, knows all the doctors where he lives, and he had cervical spine fusion. They put the screw that's supposed to go in the bone, they put it in his spinal cord. And they left it there. And they told him afterwards, we put it, but we didn't want to take it out, we were too scared to take it out. And I looked at the other screws they put in, and every single screw was in the wrong place. Literally, it was in the facet joint rather than the actual lateral mass. This is a posterior cervical fusion. Now, they made a killing on that surgery, the surgeons did, made a lot of money doing the surgery. And they left this poor doctor in so much pain, he's literally in a wheelchair. And he wants me to fix him, right? So here's what I'm saying. When we talk about how do the nerves heal, how do the muscles heal, you have to have a decompression done properly, which most surgeons will not do. So don't think you can go somewhere else, get an ACDF, and it's going to be just as good as the DLDR. You're not. If you have me do your ACDF, the decompression will be just as good as the DLDR. But anybody else, I wouldn't trust them. I've seen so many ACDFs where the surgeon did not do the surgery properly. Ah. Oh yeah, guess what? That doctor's coming here. He wants me to fix his neck. Oh, did I tell you guys? Don't you love it when you find out stuff like that in times like this? We got 2 minutes left, maybe. Ah, Jesus. I cannot get out there. Ah. This is a battle, trying to get out in the foramen, and it's so hard. So let's take the perfect scenario. You had the DLDR by me or ACDF by me. What's the chance the nerves will heal and fully recover? About 90%. What's the chance the muscle atrophy is going to go away and go back to normal? 25%. Why? Because if you're letting atrophy happen, you've waited way too long. And the nerve damage and the muscle damage is so severe with atrophy that it's really hard to get a recovery, no matter how good your surgery is.
Lights on, please.
No, I'm not done. I'm not done. Are you paying attention? Do you not see the herniation there?
I didn't watch that.
Oh, Luis is struggling here. He's been helping me, like, reduce the breasts a little south so I can get this surgery done. So, but no, we have a a tiny bit more to go. Just when I think I'm done, I find another herniation that pops out. So almost done. Almost done. Now, another thing people need to understand is when we do these surgeries, the discs, they never look normal. Okay? Actually, on that last disc that we just did, 5-6, it was kind of cool. You could see the spinal cord. I didn't point it out because I was struggling so bad, but if you go back and look at it, you can actually see the spinal cord. There's a herniation.
Is the spinal cord blue in color?
No, the spinal cord was white.
Okay.
You could see it underneath the posterior longitudinal ligament. Almost done. One more minute, I think. I'm just going to go back to this foramen and look. Almost done. All right. I think I'm going to take one more pass and we'll be done. These pieces. Yeah, I think we're done. All right. We're done. So, scope off, laser off, and let's do some irrigation. I can get those little pieces out with irrigation. All right, any questions for me?
Yes. We have a question from Pompano Mike on YouTube.
Uh-huh.
Yes, you can. Yes,
Can you tell me why you don't like Medrol and what steroid medicine you use at Deuk Spine?
Oh, we do like Depomedrol, but not for spine surgery. Depomedrol has particulate matter in it, and it causes scarring. You could use it for like knees and hips, but it can be a problem in the spine. It's not safe, but a lot of doctors use it anyway because it's cheap, and they're trying to maximize their profits on your procedure. So they'll do Depomedrol, but the problem is if you get it inside the dura accidentally, it can be toxic to the nerves. So we don't use it for safety reasons. Now, huh? Oh yeah. Oh, how is that? Right there? Okay. All right. Yeah. All right. Let's show the incision. You guys see this?
Yes, we can.
We literally lost 3 drops of blood the whole surgery. No blood. I mean, I don't count 3 drops of blood. I brush my teeth, I lose more blood. And there's the incision, 4 millimeters. You see that?
Yes, we can see that.
It's the best surgery in the world, folks, for herniated disc. All right, thanks everybody. Good job. I'll come and answer your questions face to face, so type them up. Let's go ahead and show one of our patients who had this surgery done. I'm Dr. R. Deuk. I'm here with one of my patients on February 1st, 2023. And you just had surgery on your neck, the Deuk laser disc repair done with a 4 millimeter incision to fix 2 herniated discs, her C6-7 and her C7-T1. And you had a long neck. We were able to get down to the C7-T1, and she had a very large herniation there. So your surgery was about 24 hours ago. How do you feel today?
I feel like a different person. I feel I was able to do many things this morning that I haven't been able to do for 4 months, and that is just get out of bed and just take my first steps and have 0 pain. And I haven't had that in 4 months. First step out of my bed was always the beginning of my day, and it was awful. And today I took my first step out of the bed and it was glorious. Good for you. And before surgery yesterday, you had been suffering for about 6 months with neck pain going into your right arm, correct? About 4 or 5 months. How did that affect your quality of life? Every day is difficult. I mean, I have a 10-year-old and a 5-year-old boy, and just the basic duties of a mother every single day was just unbearable and difficult. So quality of life was not very good. And so it is now. And so the pain, obviously, because of the pain, activities would set it off, so you were limiting what you were doing. You were limiting what you were able to do as a mother. Yes, there was things I were not able to do, and be the best mum that I can be this was not one of them.
Well, you look very happy right now.
I am.
Why are you so happy?
Because I'm pain-free.
Yeah, and you didn't have to have a fusion or an artificial disc put in your neck, did you?
I did not.
Did anyone offer those surgeries to you?
I did. I was offered those surgeries. I was told that I needed a fusion, the possibility of disc replacement in 1 or 2 years down the road, but it was my decision to go in and have those taken care of if I wanted to. But there was also a possibility that once the doctor got in, that he could not replace those 2 discs, so he'd have to fuse those 2. So that to me was a possible 3 fusion, 3 discs being fused. And I know the consequences of that, so that's why I came for your opinion, in your professional opinion, what can be done in a less evasive way. Or that was an option for me, and here I am.
And I'm really happy it worked out for you. You can see in the video, we were able to get down to C7-T1, which is really a first endoscopically. And, you know, because you had that nice long neck, we were able to do it. And there was huge pieces of herniation down there. Your other disc was more degenerated, and we were still able to get that fixed as well. So I'm very happy you're doing well. What's life going to be like now that your neck is fixed?
My quality of life is just going to be a lot better than what it was. I'm going to take it easy, and I know that I need to take it easy, and I'm going to be careful, but I'm going to wake up with a smile on my face now instead of tears.
Well, congratulations.
Thank you so much.
Is there anything else you want to tell your fans out there?
Come see Dr. Deuk. He'll fix your pain and make you walk out with a smile on your face.
Excellent. All right. Good to see you. Good
Thank
to see
you. Thank you so
You're
much.
welcome. Good morning, I'm Dr. Deuk. It's December 9, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he's suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes,
as a matter
sir.
of fact.
Yes, Doc. Yeah.
You're here now on post-op day 1. It was outpatient. No hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great, Doc. You know, I just want to thank you right off the bat for you and your team for basically giving me another lease on life. I mean, the back of my neck, the tops of my shoulders. I had pain all the way down the back of my arm, and my elbow, and then also I had no grip. And today, it's all back. I just, you know, it's just a game changer. His procedures. Because I've had fusions in the past, like 15 years ago, and those fusions, you don't want to do those because they just give you adjacent disc disease, and I have that problem right now on my back, and Dr. Deuk is going to fix it next week, so I'm very looking forward to doing that.
We'll be seeing him again next week after his back is fixed, but you broke it up into 2 procedures, and we get people all the time asking us, oh, can I come there and get my neck and my back fixed? Yes, you can. We'll probably do it on separate days. So you got 3 discs repaired yesterday. You can actually see right here in this video footage how small the incision is, tiny. And I was in there endoscopically using a laser to clean out the tear and remove the small herniations. And now here we sent you home an hour after your surgery, and here you are back today. And how much of that pain did we get rid of?
All of it, Doc.
100%.
I mean, 100%. And I mean, doctor did. They did surgery on 3 different levels. And through a really small hole.
4 millimeters.
Yes,
4 millimeters. Incredible.
And there's no stitches. It's just a Band-Aid.
Yeah.
You know, that's crazy. You know, if you have a fusion for three level fusion, I don't know how long that would be, but it's
it's about that long for a 3-level fusion. And then of course you'll have swallowing trouble for months, and then you'll have pain, and you'll be on narcotics. Are you on any opioids or narcotics?
No, Doc, last night I went home and to the hotel, and I just took a Tylenol PM, and that's all the medication I've taken since the surgery.
Yeah. So with the Deuk laser disc repair, you don't have to worry about getting addicted to painkillers because there are no painkillers. Literally a Tylenol, and that's it, because it's so minimally invasive. Far better than ACDF, far better than any other cervical type of surgery. Well, is there anything else you want to tell your fans out there before we wrap this up?
Yeah, I just want to let my parents know and my 10 younger brothers and sisters, if they're watching this, if you have back issues, you need to come see Dr. Deuk, because he is one of the only people in the world that can do this procedure, and it is a game changer, and it's well worth it. At least give him a review. He'll do a free MRI review for you. It's just do your research. Go to his deukspine.com, look at his website, and just do your research and give yourself a chance to do the right thing.
Well, thank you. And yes, now I'm the only one, but someday there will be another one
You hope.
who will be doing these
Yeah.
surgeries,
Yeah.
and probably better than me.
Okay, thanks, Doc. Appreciate
Thank
your
you,
help.
sir.
Yeah.
We'll see you soon.
Yep.
Good morning, I'm Dr. Deuk, CEO and founder of the Deuk Spine Institute, here with one of my patients who traveled from Mississippi,
Yes, sir. Oxford, Mississippi.
which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Deuk Spine Institute here in Florida? Okay, sorry to interrupt the testimonial of one of my patients, but we've already seen two and we're done with our surgery. Now this patient we've just completed, she had two herniated discs, number 5, 6, 6, 7. She has an anatomy that makes it challenging. Remember, we're entering the spine through the front. We make a small 4mm incision. I go down to the discs, I go past the disc, I go to the back where the herniation is. And basically, if you look at the disc, this is the front, this is the back where the herniation is. I pass my tube through the disc to the back, and then I can bring my instruments through the tube down here, my scope and laser, and I can actually operate right there on that herniation, okay? And the nice thing is you can actually wag back and forth in the cervical spine. I cannot do this in the lumbar or thoracic, but you can go from side to side. You can get the entire back of the disc. I do want to mention one of my patients is going into the pro baseball player, and I fixed his back last week. He came in and gave me this baseball signed by him, and he's very happy. His back pain is 100% gone with the Deuk laser disc repair. We do pro athletes here, and they love it because the surgery works and they don't have any metal or fusion or bone loss. That's the other types of surgery have. All right, let's get to our questions.
Before we get into our questions, doctor, how would you rate the surgery out of 10?
How would I rate this surgery on a scale of 1 to 10? I would give this one an 8.5. 8.5 out of 10. I've had 11 out of 10 before. You know, the good news is we're actually able to visualize on the lateral x-ray the number 5-6 disc as well as the 6-7. I've had surgeries where it's been even harder than that. I've had surgeries where I'm fighting the collarbone. You can all see the collarbone right here. It's rigid. If the disc is below the collarbone, you can't get to it. So I've been up against the collarbone, and those surgeries are 10s and 11s out of 10. I don't go higher than 11, but yeah, she was about an 8.5. So she was very hard, but we still had enough space and room to get everything done. We did have to compromise a little bit. I couldn't get 100% of the foramen out. I probably got 60% of her herniation if I had to pick a number, 60%. And the reality is you need 50% of the herniation out to get elimination of symptoms permanently. So I think we're there with her. We'll know tomorrow when we see her.
Does it mean that the incision was made very close to the collarbone?
That's correct. So in her case, the incision, in the past I've had incisions right up against the collarbone, so it's really hard to move the metal instruments. But in her case, it was a little bit higher than the collarbone, so I had a little bit of room.
Okay, let's get into the questions. We have a question from Luis Mercedo on YouTube.
Hello, Louis on YouTube. Thanks for asking a question.
I had a fusion of L4, L5, S1 that didn't go that well. can those surgeries be reversed and the hardware be removed? Fusion was done 3 years ago and I am still feeling numbness in my feet and spasming in the muscles.
So Lewis, you had a fusion done at L45, L5S1, and you want to know if that can be reversed. It cannot be reversed, but your symptoms that you're having are not coming from the fusion. They're coming from something else. And it could be above the fusion, at the fusion, where the nerves are being pinched, but the fusion itself is not the cause of your symptoms. So you do not need to reverse the fusion. That will do you no good. What you really need to do is come to Deuk Spine Institute and we can get you fixed up. I would start by doing the MRI review. It's free. You just send me a new MRI so I can see what's going on, and I will tell you why your feet are numb. I will tell you why you still have back pain, and I can almost guarantee you we can fix it. I would say with 99% confidence we could fix it for you. I just need to see your MRI. Possibly we need an X-ray and a CAT scan and a nerve test, but we could talk about that at the time if we need it.
Okay, the next question's from Big John on YouTube.
Hi, Big John. We verified Big John, by the way. He really is big.
Okay, so the question is, weight restriction post DLDR is 25 pounds, the same for 150 longs person as it is for, say, someone 290 pounds. Does size matter, or is 25 pounds just a rule of thumb limit?
Great question, John. So 25 pounds restriction is a rule of thumb. We don't know the magic number. It could be different for different people. The problem is if you exceed the 25 pounds, then you're playing Russian roulette with a reherniation. Of course, a reherniation would be the concern. What is a reherniation? A reherniation is when we go in and remove the herniation and clean the tear, and the disc is very happy now, it wants to heal, it can heal, but then the patient does something within the first year, they do too much, and they put pressure on the disc and they pop out another herniation. And that new herniation is going to block the disc from healing. We call that a reherniation because they reherniated. Reherniations happen in surgery, they even happen with the Deuk laser disc repair. We can't prevent them 100%, but we can try to minimize the chance that it's going to happen. So to do that, we have restrictions after surgery. The first restriction is a 25-pound lifting restriction for 6 weeks on any Deuk laser disc repair surgery. After 6 weeks, it goes to 40 pounds. These are just rules of thumb. It could be, it's never needed to be less than that, but you could raise the limit a little bit, maybe get away with it. It's just that that's based on our experience. So I've had patients tell me they've lifted 50-pound suitcase and then they feel a pop and they reherniate. Give me 1 second. Hello? Hi, I'm in the middle of a live stream. Can I call you right back?
Absolutely.
Thanks. My patent attorney. I had to take the call. So this reherniation concept happens with almost any type of spine surgery, as I was saying, but it even happens with our surgeries, Deuk laser disc repair, because when we're done with the surgery, there is a small hole back there, about 3 millimeters, and your body has to seal that off. It will. Your body will form collagen, and it will seal it off. By the way, the annulus, which is the wall around the disc, is made from collagen. So you're basically just recreating the disc, the annulus part. You cannot recreate the nucleus.
The next question is from Pompano Mike on the steroid medicine. He asks, if you are doing a transforaminal epidural injection for an impinged nerve at, say, L3 or L4, what steroid medicine do you normally use?
So the question is, if we're doing an epidural steroid injection in the lumbar spine, transforaminal 3-4, first of all, I don't typically do those. Dr. Patel, Dr. Francis Cini do. But they use a steroid called dexamethasone, or dexamethasone, and I think it's called Decadron as well. That may be betamethasone. Anyway, there's a whole bunch of different steroids that are out there, but that's the one I believe that they use. It's more expensive, but it is safer, and it's very effective.
The next question is from Ali Cameroon on YouTube. If the neck is bent back for the procedure, does this make the herniated material collect better in one spot by pressing the bones closer together versus upright neck?
Yeah, so Ali Cameron, thanks for asking a question. No, bending the neck back doesn't do anything to do with collecting the disc herniations in one spot. It's just about getting access to the spine and reducing the amount of soft tissue in the way to get to the spine.
We have a last question from Amartos on YouTube.
Amartos?
Do you have statistics of your patients on how they do 1, 2 or 5 years after the surgery?
We do. Yeah, we followed our Deuk laser disc repair patients out 6 years, and they have an average of 92% of their preoperative pain is still gone in their spine and down their extremity, into their leg or arm. So 92% is our average elimination of pain at 6 years after surgery.
We have a follow-up question from Ali Cameroon. Doesn't the body eventually clear out the herniated material outside of the annulus by dehydrating it?
No, the body never clears out the herniated material.
I think that's all the questions we had.
All right, very good. Nice talking to you all. We'll be back shortly in about 30 minutes with our next surgery. It's a patient who travels to us. Do you remember where he's from? So this patient was from Indiana. The next patient, I'm not sure, I have to look and see. But he has herniated discs at L23, L34, L45 on the right side. He has stenosis and radiculopathy with pinched nerve on the right side. He also has facet joint pain. So we'll be doing his Deuk plasma rhizotomy for the facet joint pain. We'll be doing the Deuk laser disc repair for the disc pain, all at the same time. So please join us